So while people are settling down, I'm actually going to start just so that we can try to stay on time. My name is Stuart Finder. I'm the director of the Center for Healthcare Ethics at Cedars-Sinai, and I've been working with Kukla in helping to organize this. And my job is to help us in the transition, maybe be a little disruptive here, going from the panel to the next part of our program as we shift to a more local focus of our conversation. And to begin that shift, we're going to hear from Ms. Jennifer Kent, who is the director of the California Department of Healthcare Services. Ms. Kent, who completed her undergraduate studies at St. Mary's College of California, just a little bit down the road from here, and then her master's in public administration at USC, has since 1999 spent her career working with a variety of California-specific healthcare industry-related organizations. She started in the lobbying world, working with the California Optometric Association. Then she shifted to government for a number of years, working in the Department of Health Services, the Health and Human Services Agency, and the Governor's Office, before she then went back to the dark side to lobbying. And actually was the executive director of the local health plans of California for a brief period of time before the government lured her back to become the director of the Department of Health Services. And given this wealth of experience that she's had well over a decade and a half in the government, her job is to help us really start to focus in on what's going on as things are seen in Sacramento. So I now turn it over to Jennifer.
Thank you so much. And I had warned folks that I don't like my bio being read because it essentially looks like I can't keep a job. So when you start to look at all the different things that I have done, it looks like I move around a lot. And I think what I really wanted to come and share today was, the importance of where my department is in the grand healthcare delivery system within California. So, I have approximately 4,000 employees. I oversee a budget of upwards of $105 billion in spending annually. We run 6 different delivery systems by and large. So I know when people think about Medi-Cal, they think about, oh, managed care or fee-for-service, and you kind of stop at that. But within our department, we have managed care, fee-for-service. We have the specialty mental health services that are run through 56 county mental health plans. We are setting up and running a substance use delivery system through counties. We have the California Children's Services Program, and then we have dental fee-for-service and dental managed care. So each of these systems have their own rules, their own financing, their own eccentricities, if you will. And then, at the end of the day, you have approximately 13.5 million Californians that rely on us for not only the financing, but as well the care and the quality of the care that is delivered through these various providers and delivery systems. And so what I kind of wanted to share, and I don't fly with slides because I don't like sitting through PowerPoint presentations myself, so I try not to do it to others, is I wanted to kind of lay out some of the data that underlies a lot of the decisions that we make in our Medi-Cal program, and some of the data that helps drive some of either the decisions or the problems that we grapple with at the state level, kind of concurrently with all the other things that compete for time and resources over in the Capitol. So the data that I'm going to kind of use is off of a presentation that I have done in conjunction with one of my data analytics experts. We have shared it not only through the California Healthcare Foundation, but also through Medicine X. So I don't know if anybody has ever been to the Medicine X or at Stanford. I always call it the sneaker hoodie crowd. So it's like all the angel investors and all the private equity guys get together with all these really smart people, and they want to sell you like an app or a data something. And so they asked me to speak a few years ago, and I was like, hey, I'm here, and I run this sweet little program called Medi-Cal, and and nobody knows what I'm talking about. And I said, yeah, but I have like $100 billion budget. And then all of a sudden, everybody was really interested in what my program had to do. And, you know, people wanted to sell me, one of my favorites was they wanted to sell me drones that dropped buprenorphine at people's houses. And then someone else had a light up cane that the light would show someone's, I don't anyway. And I'm like, I don't have a warehouse. I don't buy things and distribute them myself. But it was really sweet. So taking a step back, so when I did that data presentation at Medicine X, I was essentially challenging them to say, help me solve the problems that I get every day in terms of the populations or the opportunities that we have to better deliver care. So same principles apply with you. When we look at our population in our data warehouse, it shouldn't be a surprise that the top 1% of our population generates about 64% of the total spending. So when you think about what that is in a 13.5 million member program and $104 billion in budget, that extrapolation works out to be a pretty significant amount of money. 5% of the top spending population is about half of the spending on eligible populations. Ironically, the healthiest people only spend about 9% total. So when you look at kind of families and children, which is a lot of our population, those are some of the easiest and least costly populations. And so it's not necessarily volume, but the care and the cost are really concentrated in a very, very small amount. And you say, well, who are these people? 71% of the 1% are in our aged, blind, and disabled categories. Again, not necessarily a surprise. And when you look at what those costs are broken out in that 1%, about a third of it is hospital inpatient care, about a third of it is on in-home nursing or skilled nursing, in-home supportive services, home health, and then the rest is kind of scattered among pharmacy and some other things. And then you take those really expensive disabled populations and you say, what are the top occurring conditions in that population, among others? And you find out that mental illness of any kind, either serious, mild, or moderate, is 59% of that 1% population. So when I sit and think, you know, how am I working to deliver better care, and who are these people that we're so closely targeting, a huge number of them have some kind of mental health condition, and then followed the next closest condition is hypertension. So, and I'll get to some data that actually makes it even more interesting. When you look at the 10% of the population, and I'm only in my fee-for-service population, 254,000 people, so 254,000 out of, at this point when the data was pulled, was about 9 million people. They generated $7.5 billion in spending. So 250,000 people, $7.5 billion. And then we say, and this is my favorite question, and I'll ask you, one person in my program, a single individual, guess how much they cost in a single year? And just throw me some crazy dollar amount. I hear 1.5, not even close. Not even close. I heard 10. Keep going. No, not 100, thank God. 21 millions for a single person in a single year. And I have at least 10 people that cost over $5 million a year. So we kind of move into that and we say, you know, what are we doing to solve this, and what are the kind of things that we can do to better target services? And so innovation in government, I know that people, that's like a great new buzzword, is what are we doing to innovate? And in government, we're not necessarily buying, like I said, apps or lighted canes, or we're not flying drugs around via drone, thank God, because that would be a lot of drones in this state if we were doing such a thing. But I will kind of call you back to 1994 when we, the state, said we're going to provide prenatal care to any woman under a certain income level, regardless of their documentation status. Not necessarily particularly innovative. I mean, it just was like, hey, this is good policy. We're going to spend some money because we think that we can impact birth outcomes. And what you see when you look at national data versus our data in terms of positive birth outcomes, improvement in low birth weight, and reduction in infant mortality and morbidity, you see the national numbers going like this, and you see the California numbers going down, whatever that line looks like to you. And there's a demarcation that is really fascinating, and I think that I like to point that out and say that was innovative from the standpoint of only government is able to take such a large societal problem, apply the full weight and scale of its resources and its time and its infrastructure, and solve a problem in that way that no other private industry, no matter how well financed or how well intentioned, can actually effectuate. So that draws us to 2015, and we were using this data that I kind of referenced in terms of who are our high-cost populations, what do they look like, what is causing their conditions to be either exacerbated or unchecked. And so we have opportunities with the federal government to do what's known as a Section 1115 Medicaid waiver. And this is my third waiver. And waivers in the past have usually been solely focused around hospital financing in the state of California, which for good reason, right? Key provider, key safety net, key chain in terms of the delivery system and the backbone, and those are really complicated waivers. But we got to a place with the federal government where we were like, we need to go beyond hospital financing, and we need to start reaching more broadly into both populations and into the less kind of traditional hospital situations in terms of getting people out of inpatient care and really focusing on driving outcomes on a lower kind of level of care. And so we came up with a variety of solutions, but we developed something called whole person care, which is, again, not very innovative, doesn't sound like a whole lot of revolutionary, I thought. But the idea was that we're going to look at individuals, we're going to look at all the different delivery systems that they touch. We are going to require that all of those different local entities, meaning county public health departments, county mental health departments, public hospitals, community-based organizations, FQs, managed care plans, you name it, they're all going to have to, gasp, talk to each other. They're also going to have to share data, and they're going to figure out who these people are, because we can almost guarantee you that the top highest users are in each of these delivery systems, and they don't even know it. And we're going to force them to do something to address all of their needs, both medical, social, and in some cases, housing. And so we have about $1.5 billion over 5 years where we have chosen counties based on their applications to us, and they're providing things such as sobering centers, mobile outreach teams, supportive housing, crisis, all different kinds of services to kind of holistically envelop individuals that are, as you would probably know as healthcare providers and health policy experts, they boomerang into all these different settings, and you may want to do the right thing for that individual when they're sitting in your ER because you're an ER physician, for example, and then they get discharged and you no longer have a tie to them. And so what we're really trying to do is say, when someone comes into the ER, what are we doing to not only make sure that they're treated appropriately, but that they're handed off to someone that can handle some of their longer term or more challenging issues that an emergency room is not positioned to do. And so some of the data that has been interesting for us, and we wouldn't be anywhere without our data, and how the federal government wants to be able to justify the investment that it's made, is we've got a lot of different metrics and measures that we're looking at, but some of the basics are, is jail recidivism being reduced? Are people using lower levels of care? Are they having more primary care visits, more mental health consults rather than boomeranging in and out of the ER? I think one of the individuals that we brought as a case study for you, just to kind of get a sense of, is we have one individual who's in our pilot. She's 53. She's disabled. She's not homeless, so that's actually surprising. She's in the 1% highest cost. In the year that we looked at her, she was $185,000 and higher. She had 407 physician and clinical claims. She had 91 pharmacy claims. She had 1 short Doyle visit. I'm going to come back to that because that's important. She had 47 ED visits, 51 hospital stays. She was in the hospital for 148 days total, average length of stay 2.9. The PQI was 24, and her prospective risk score was 8.31, and she had 11 disease conditions identified. alcohol and drug dependency, back disorder, congestive heart failure, COPD, coronary artery disease, diabetes, hypertension, mood disorder, pneumonia, respiratory failure, schizophrenia, and septicemia. That one visit that I referred to, the short Doyle claim, that's our specialty mental health service. And she had one claim in a year. But she also is noted as having mood disorders and schizophrenia. And so the challenge I think that we are facing broadly as a state and more specifically in my department with the population we have is what do we do to better align the different delivery systems such that the patient isn't expected to navigate them, but that we are targeting and more closely identifying and do a lot of deep intensive work on those individuals because the care that they are getting is clearly not meeting their needs, and it's obviously having larger impacts on us as both a delivery system, use of resources, and quite frankly leading to really poor life outcomes for these individuals, since we know a lot of the individuals with serious mental illness die on average 20 years earlier. I think what I would like to also just kind of leave you with, and I'm happy to answer questions because I'm also not a big public speaker in general, is when I think about the things that we face as a state long term is, when the economy is good, it is really awesome, right? This building right now is on, they're on cloud 9. They got so much money they can't believe it. And they've got all these great ideas for how they want to spend it. But the day that the economy drops in our state, my program goes into what I say cognitive dissonance, in that as money is disappearing from state coffers, my caseload grows exponentially. And so I'm inversely impacted by an economic downturn, which is I receive higher numbers of individuals seeking care just at the same time that we're also having significant reductions in general fund. And so I think some of the challenges that we are having, and this has obviously been part of the governor's messaging all along, and this is what California, together from a policy standpoint is going to have to face, is what are the investments that you make? When do you make them? How do you make them? Are they long-term? Are they short-term? Are they one-time? And if you are going to make a long-term investment, what does it look like? What are the deliberate outcomes that you are going to be demanding? And are you going to have the ability to course correct should the economic circumstances change? So I think, you're here at a really important time in state policymaking. I lived through the 2008-2009 recession when I worked for the previous governor, and it was really terrible. I can't stress enough how awful it was, and the number of people that came and met with us and shared, their personal stories of how they were going to be losing key services. In some cases, we were potentially jeopardizing their ability to remain in their homes and be institutionalized or be homeless. We were doing, awful things to foster kids. We removed all the optional benefits. I mean, you name it, we had to do it. And I remember someone saying to us, you're making a really bad policy decision. This policy decision doesn't make any sense. And I was like, we passed the point of good policy versus bad policy a long time ago. Now we're just making decisions because you don't have any money. And that's what happens when you are a state general funded program like I am. But I think, right now it's almost... it's somewhat kind of ironic that I sit in a place in which we are at our highest revenue and highest resources as a state, and yet I still find myself, as a director saying, whoa, don't go crazy, because I can see, I know, if you've looked at the history of the state of California, this economy will drop again, and I will be back in a place where we have to be making really, really awful budgetary decisions. And so, you coming to grapple with those high-cost individuals, be it the population that I'm talking about specifically in my program, or individuals facing serious illness that are outside of my program or even within my program, those are the kinds of decisions that I think are really both timely but also just important from a societal standpoint and what we do to overall kind of strengthen the safety net for everyone. So with that, I'm happy to answer questions and happy to be a part of the discussion. So
Jennifer, you mentioned considerations of how do you manage through those swings. Could you elaborate a little more on some of the thoughts that are out there in that regard?
Sure. So if anybody knows, and I assume you probably don't follow the esoteric budget the way I do, if we have about $104 billion total funds, about $60 billion of those are federal. cannot stress enough how critical the federal partnership is to us from a Medicare, Medicaid services portion. But I think, to the extent that the discussions were occurring last year around, per capita cap or block grant, you saw a fair amount of wide-eyed panic from both me and the Medicaid director, because we were running numbers and we were building models saying what happens to us as a state if the federal circumstances change, that our federal funding is somehow turned off or limited in some way. Once you leave the federal funding in our program, there's both state general fund, which is obviously critical. I have about $22 billion in state general fund that we have in our budget. But then the remaining difference is, we call it non-federal share. So we use a lot of revenues in the state that you wouldn't traditionally think of. So think of county funding. We have a lot of intergovernmental transfers that we bring up from county governments. We work with our hospitals on a lot of intergovernmental transfers. We have a lot of provider taxes. There's a hospital quality assurance fee. There's a skilled nursing fee. We have a managed care tax. So we have worked with each of those industries, and they are big industries with a lot of both resources available to them, but strong interests in helping support provider taxes like that. So we will collect provider taxes, say, from the hospitals. We take it up to the federal government. We show them the money and say, here's the non-federal share. We draw down the federal funds, and then we distribute it back out. That's, I think, it's like a $5 billion a year type of financing mechanism. Cannot be understated how important that is. So when we talk about budgetary impacts when the recession occurs, in the back of my mind, there are always options in terms of what are your quick, easy ways to bring your program under control. You look at optional populations. You look at optional benefits, and you look at rates. And so those are the three-legged stool of how any Medicaid program works. So do I have to cover this population? And I have a lot of populations that I don't have to cover. We have chosen to cover them as a state, but they're not mandated. We have a lot of optional benefits that we provide, and you immediately can go to those and say, do I have to provide those optional benefits? Dental was one of the largest optional benefits that we eliminated in 2008. Ironically, in Medicaid, pharmacy is an optional benefit. And I find that to be really odd, but it is. Because what would happen is if we eliminated and no one's ever seriously talked about this because of what would happen. If you eliminated it as an optional benefit, it meant that anybody needing a prescription or a pharmacy filled, they just go to a hospital and you could actually get it through a hospital. So we know that that would not be an efficacious way to achieve that. And then you look at rates, and this is when providers start, squirming in their seat, and I can see Tom squirming right now. We look at how much are we paying you guys in terms of providers, broadly speaking, and so those are the three main buckets. There's not really, when you're in a big state economic crunch, there's not a soft savings target, right? Because the governor and the administration have to put forward a budget that actually balances. It has Wall Street implications, and so we can't go to Wall Street and say, oh, we've got investments that we're making so that we will save money in the out years. It doesn't work that way, and so I often know in the back of my head optional populations, optional benefits, optional rates that I can change, and that still nets out to be not as much as we would like. But I think, again, to the governor's credit, the institutionalization of a rainy day fund from a state perspective, as well as both the governor and the legislature's willingness to take that up as high as they have, will certainly smooth some of the bumps in the road in the future, but again, can't withstand a long and deep tranche of a recession, especially for a big program like ours.
Thanks for that excellent overview of the scope and complexity of the services that Medi-Cal provides. Can you speak a little bit to Medi-Cal's work or goals in regards to access to palliative care services?
Sure.
And if possible, around the different populations, Medi-Cal fee-for-service, managed Medi-Cal, as well as the pediatric population?
Sure. So there was a bill that was passed a couple of years ago by Senator Hernandez, who, coming full circle when you talk about me lobbying for the Optometric Association, Senator Ed Hernandez is a fill-in-the-blank. That's right. And he was my board chair, my PAC chair. He was the he was a lot of leadership positions, and he was not even remotely thinking of running for the legislature at the time that he was. And so, full circle. So it was a palliative care bill by Senator Hernandez that essentially said that we needed to offer, or we should be offering, a palliative care benefit within the Medi-Cal program. And so when we don't ever, or I won't say ever, because there's always an exception, it is traditional in Medicaid that we don't have benefits in one system without being the other, because we have to have comparability. So unless you have a waiver to provide a service in a particular delivery system, it's kind of consistent across. So in both managed care and fee-for-service, we have a palliative care benefit that we have rolled out. It is targeted at certain populations, and to be fair, I can't remember exactly who they are, but I know end-stage cancer, there's 5 conditions that we've identified. These individuals are eligible for palliative care, and we've worked with the plans to kind of define what that benefit looks like in terms of the additional and or enhanced services that should be provided to that population. I think in many cases, it wasn't a big, necessarily a shock to the plans, because those services are already contained in their contractual and scope of responsibility. So it was more of a, hey, heads up, this population, for these individuals falling into these categories, you're going to have to provide a little bit more concentrated and or strategic service around them. For pediatric palliative care, there was a bill that I was a part of back in 2004 that created a pediatric palliative care waiver. And so essentially this is a waiver, so we get to treat people differently in a different setting. So we had certain counties that opted in and kind of raised their hand and said, we would like to be able to provide palliative care services to children, not necessarily hospice services, but any child either facing a terminal illness or having a serious life-threatening chronic condition. And so it was a waiver set of services that are specific outside of our state plan, that these waiver agencies were able to provide palliative care services to children and their families, such as respite, things that are not necessarily our traditional Medicaid services. That program, the waiver has expired, and we're working with CMS to kind of figure out what we do in terms of next steps. But I think what we've had challenges on is finding kind of the pediatric expertise in palliative care. It's certainly a lot different in some cases, and I think we want it to be different, right? Because children, kind of require a little bit different set of intensity, different kinds of therapies that maybe would not necessarily be fully applicable to an adult population. So we're kind of contemplating what we're doing on the pediatric palliative care side, but I think, and I'm sorry that I missed the panel earlier, because I was just confessing that my husband makes fun of me because that's basically my fun reading is hospice palliative care books. And he's always like, why are you reading all these books on death? And I'm like, it's really interesting. It's fascinating stuff. So I think, I come to our palliative care services and programs in the Medi-Cal program, which is how do you reckon with a serious illness, or in some cases the start of a terminal diagnosis is the best and most appropriate place to have the conversation. But I think in many cases, not only is the patient not able to hear that conversation, they're not ready to have it, providers are not wanting to have it either. And so speaking just from my own personal experience from a parent that passed away at 59, I was the translator between his hospice oncologist and my family, saying, okay, these are the options that are available to us. How do we make good choices? How do you want to spend the rest of your life? Are you focused on quality? Are you focused on quantity? And so I kind of bring some of that approach into some of our work around either terminally ill or significantly chronic conditions. And, the whole person care pilot's not necessarily about palliative care services, but there's obviously a continuum of delivery systems and mechanisms that we have about how we kind of work with that population. So I appreciate that question.
Yeah, I was very interested to hear about your work with some of the individuals with mental illness, the individuals that are living borderline lives, and the expenses as these people can incur. They practically live in our emergency rooms. I'm at UCLA. And one of our projects that we've been trying to do is actually do advanced healthcare planning with this population. It's very interesting in our discussions with them to find out that many of them really would not want to have a lot of the aggressive treatment they find themselves with at the end of their lives. And yet, so often it seems like these conversations aren't taking place, rather from lack of resources or just generally, in some cases, going out amongst them and talking about it. Whenever we're talking about these populations, is there any kind of a benefit within your system to having these conversations with these disenfranchised populations?
You know, I think I would take a step kind of back off of that and say advanced care planning, advanced directives are probably part of any conversation that a provider should have. I wouldn't want it targeted just at some of our population or a piece of our population, because that would feel that we would be trying to kind of prioritize or say, hey, you know. But I think by and large, when we look at changes in Medi-Cal or benefits that we want to add or incentivization of provider behavior, I think I would say broadly writ, since we have a third of the population in our system today, I would want providers to be having those conversations, or at least offering that opening in whichever situation it's in, be it an ER. So we, this is slightly tangential, but you know, we also pay for the, I love to say SBIRT, but it's the screening and brief intervention, referral and treatment for alcohol and substance use, and we pay for that as a benefit, but only in primary care settings. And so again, logic, I'm like, if you've just basically done serious harm to yourself and you're in an ER because you either overdosed or you were driving drunk and you crashed your car, it seems to me, logic, that we would be like, hey, you're in the ER. This is a moment in time that you might have some clarity around. Let's talk about your life choices. And yet we only pay for it in the primary care setting. So I'm tangentially working my way back to your question, but it seems to me that in a primary care setting, that's not when you're kind of at your lowest ebb saying, wow, I really need some help. So we're looking at some changes and there's some pending budget issues, but I think that also goes around advanced care planning. I think sometimes if you have someone that is either, in some populations for the seriously mentally ill, you have to wonder about their mental competency at all. And you don't want to have a conversation with someone at a place in which they're floridly psychotic and say, hey, this is about the time that we should talk about it. But I think also in a more thoughtful and careful setting, any population within our program should be like, hey, do you have wishes? If something were to happen to you, either from a chronic standpoint where you have a terminal illness where you have a little bit of time to think about it, or if something happens to you on a traumatic basis, what do you want to express as your wishes? What does your family know about your choice? Those are all great conversations. And I think broadly writ, we as an administration want to be thoughtful about how we incentivize those to get those into place. And I know there's been some thought around, trying to create registries and things like that, which I think are harder. But I would say we're always open to wanting to have either physicians or clinical social workers, MFTs, whoever's appropriate to kind of initiate and kind of help triage, because a lot of people just don't want to have the conversation, whether they're in my population or whether they're kind of broadly writ in the overall general public. So thank you so much. Yeah, thank you very much.